So we are recording our session today, and let's get that up there out of the way. All right, so here we go. Now, we stopped our discussion on Monday at atherosclerosis, and atherosclerosis at its very base level is what, Juju?
Not sure.
Somebody help her out.
Isn't it fatty tissue deposits with high cholesterol?
No, it can be any deposit in the artery. So it can be fat, it can be cholesterol, it can be blood clots, and that turns into plaque after a while. It gets really, really hard. It reduces the blood flow distal or beyond. The word distal means beyond a particular reference point. So it reduces blood flow distal to where that plaque is. And as such, then your oxygen demand can outpace or outstrip what the availability is, and the patient can start having some chest discomfort, pain, tightness, pressure, or whatever that's going on whenever they exert themselves. And keep in mind that this exertion could be as simple as just simply walking across the room. Now, this is known as angina, angina pectoris, Angina Pectoris, angina pectoris. Now, the way that the patient deals with the pain is in a couple of ways, okay? And again, this is not a patient having a heart attack yet. This is an early warning system for this patient that is having this major issue, okay? So basically, we can either have the patient stop and rest. Now, the demand equalizes with the supply, chest discomfort goes away. Or they can take a medication to help to increase the blood flow. What did we say that medication was?
Can you repeat the question?
Uh-huh. So what is the medication that a patient can take that will help to increase blood flow beyond where that blockage is?
Would that be beta blockers?
No, that's
Maybe dilatation.
they can take a beta blocker, but we generally don't administer for that joke.
The aspirin?
Aspirin helps to keep the blockage from getting worse. Okay, and again, aspirin is going to be the most important drug that you're going to give when you get on the scene of a patient complaining of chest pain. Cece.
Would it be nitroglycerin?
Nitroglycerin. Now remember, nitro causes that vasodilation, and as such, it makes the vessel larger in relation to the blockage that's there. So, right now we have more room for the patient to get more blood to be able to come around that, and the patient's chest discomfort now dissipates. It goes away. They don't have it anymore. Now, here's the thing to keep in mind. Patients who have angina, and we talked a little bit about stable versus unstable, and we'll talk more about this in just a minute. Patients who have angina are at a great risk of that clot or that blockage getting worse, so that it occludes all or almost all of the diameter or the lumen. That's what lumen means, is the diameter of that artery. When it blocks off and there is no blood that gets beyond there, now what happens to our patient? Juju.
Would it start to die?
And what do we call that?
Infarction.
Infarction. Okay. Infarction or necrosis of tissue. Either one of those would be an appropriate answer for that. And again, remember, when the heart tissue dies, it can't pump, it can't conduct electricity. And those are two incredibly important things that the heart tissue really, really needs to do. Now, we talked a little bit about a condition known as Prinzmetal's angina. Prinzmetal's angina comes about as a result of vasospasm. Basically, what happens is the artery clamps down and it gets so small that, again, the same premise takes place. The amount of blood that gets through that area where the artery has had the spasm is so low that the O2 demand is greater than what the supply is. Therefore, your patient now begins to have chest pain. All right. Now, here's the thing to remember on this. I won't test you on this, but just hold on to it for advanced cardiology. Nitroglycerin is not effective in this type of patient. All right. What we do want to give them is some type of like a benzodiazepine that relaxes muscles, that goes in and targets the muscle of the artery and relaxes it. All right. Now, we will start off with nitroglycerin for these particular patients, but generally, nitro is not going to help them. And we get this information from patients that are going to be honest with us and tell us about their drug history. And so if we have that, then your patient can actually lead into having a heart attack, Kim, because that spasm can get so small that almost no blood gets through. The end result is the same, Teray. No blood, no tissue survives. It dies off. It infarcts. It undergoes necrosis, and that tissue dies and it no longer works. Now, here's the thing to keep in mind. Not all causes or not all chest pain is going to be cardiac in relation. You can have patients that will have chest pain from a number of different reasons. Trauma, overuse. For example, over spring break, I picked up a cold and I've been coughing a lot at night. I'm not contagious, or else I wouldn't be here, or I'd be wearing a mask. But my chest is sore. Why? Because I keep stretching these muscles beyond what they're normally used to. So keep in mind that with a patient that has cardiac pain, that the pain does not normally change on movement or palpation. And what is palpation? Palpation is when we come in and we push on the body anywhere. Okay? So, Cece, if you're looking at your patient and you're pressing on their chest and they go, "Ooh, that hurts right there," that's probably not cardiac, okay? Bella, when you're assessing your patient and you ask them, does the pain get better or worse when you take a deep breath? And they say, yeah, it gets a lot worse when I take a deep breath and it gets better when I let the breath out. That's probably not cardiac. Remember, there's rarely and always or none or never in medicine. But that's the thing I want you to kind of remember. Shoulder injuries can also lead into types of chest pain, okay? Because the same muscles or the same nerves that relay the information about the pain from the shoulder to the brain also come across here into the chest. And so we can have what's known as referred pain. The pain is actually originating from someplace else, but it's being referred or felt in another place. Give you an example. Probably none of y'all have had this because you're too young, but have any of your parents or your grandparents ever had problems with their gallbladder? Okay. What kind of symptoms did they have, MG?
Side pain, right about under the rib cage and down.
Yep.
Nasty GI movements and
Yep.
sometimes vomiting. Sometimes the pain can radiate up into the right side of the chest.
Stop right there. Thank you. You did that perfectly. And we didn't even rehearse this, okay? So again, not all chest pain is cardiac. So if you got a patient that has gallbladder pain, yes, the pain is going to be right in here. And she's right. There are some nasty GI side effects from this, okay? But they'll also have referred pain up into the right side of the chest and to the right shoulder. This can make you think, Joe, is my patient having an MI or are they having a GI problem? Your rule is going to be treat what's going to kill your patient first. So if you're looking at this, does my patient have a GI problem? Correct medical term in that is called cholecystitis. Or are they having a heart attack? The first thing we're going to do is we're going to either rule in or rule out a heart. All right. So we're going to work our patient up. We're going to get a 12 lead. We're going to give them aspirin. If we need to, we can give them nitro. If it comes back, let me ask you a question. Let's say that you give a gallbladder patient nitroglycerin. You get to the hospital and they find out, well, this wasn't their heart, it was their gallbladder. Have you done anything wrong? No, not at all. Not at all, because what you're doing is you're working off the information that is available to you outside of the hospital to treat your patient. Bella.
So like, you said that like a lot of times there's like nasty GI issues and like dealing with like gallbladder issues. Like if you get nitroglycerin and since it's like a vasodilator, what would it like? Could it like be dangerous to the patient if you're trying to treat the heart, but it's going to like the gallbladder that's bleeding?
Mm-mm. No, and again, what you're going to want to do is you're going to assess what is going to be the one thing that you're got to critically assess for before you give a nitro.
Blood pressure.
Blood pressure. So even if your patient is, let's say that your patient is having a gallbladder attack, and their blood pressure is 88/60, we're not going to give them nitro. Not because they're having a gallbladder attack, which we think they might or might not be having, but we're not going to give it because the blood pressure is too low. Same way as if the chest pain was right here and we were pretty sure that they were having a heart attack, we're still not going to give it. So giving them a medicine and coming up and finding out, oh, well, it wasn't the heart, is in most situations not going to be a bad thing. When you get into advanced cardiology, I do a lecture called STEMI Imposter. STEMI is another name for a patient having a heart attack. But in that lecture, we talk about things that look like a heart attack, but really aren't. They're somewhere else. Okay, good question. All right, so again, as far as you can have your lungs and the lining around the lungs, they can get infected. All right, you get pneumonia, you get bronchitis. Sometimes it will, when you breathe in, it hurts. You can develop a condition known as pleurisy. On the outside of the lungs, just like the heart, they have a lining. Okay, and so the lungs slide back and forth against that lining. Right when you get an infection, some of that fluid that is in there actually dissolves. It goes away. And now we've got kind of like, rather than fluid in between those two pieces of tissue, what you've got is leather on leather. And so when you breathe in, it causes some problems for our patient to go through. Mediastinum. Your mediastinum is up here in the center of your chest. We can begin to have problems with the aorta, particularly when we were talking about on Monday about aneurysms, and that can lead into chest pain. Not pure cardiac related, but it is related to cardiovasculature. And then we can have what's called psychogenic, or we've talked about the abdomen, but we can have psychogenic. Basically, it's kind of like, I'm not sure why you're having pain, or it could be stress related, as related to a patient that is having like a panic attack. Understand when a patient is having a panic attack in relation to anxiety or stress. Be very compassionate with them, okay? I don't know if you've ever undergone anxiety, but it is terrible. It is terrible. And the symptoms that your patient feels are very, very real to them. Now, when you're looking at them, we're going to treat them, and you're going to be professional and you're going to be compassionate, but we're also going to know that we don't have to go down the route of treating them for cardiac when we're pretty sure, and we're never going to be really 100% sure of what we're dealing with out in the field, just simply because we don't have all the information coming in, Lucas. But when you're pretty sure, just be very professional with them and compassionate. All right. Now, let's talk about, yes, ma'am.
Can you explain like the difference like between coronary artery disease and atherosclerosis?
Yeah. So, go over here to my board. So we've got atherosclerosis. Atherosclerosis, and that's an R, not a V. Atherosclerosis comes about when we've got our artery here. And who can tell me what the precipitating cause of heart disease is?
Inflammation.
Thank you so much. Okay. We get inflammation inside the artery. And inside the artery, when that inflammation begins to build, the lining of the artery, instead of nice and slick and smooth like Teflon, it gets roughed up. And in that process, the lining of the artery gets lifted up, kind of like this. And now we begin to get all kinds of stuff that comes in underneath that flap that comes up. Eventually, that flap will get bigger and bigger, okay? So that is a specific type of cardiac disease. Okay, so atherosclerosis is a type of cardiac disease. When this builds up and our ability to get blood going in through the artery now begins to be diminished, that leads into another type of cardiac disease that is known as angina. Make sure you know the second name of it, but in the real world, as you know, nobody calls it angina pectoris. We just refer to it as angina, all right? So that's another one. This is where the O2 demand is greater than your supply. And the patient begins to have discomfort. They begin to have shortness of breath. They may even begin to become diaphoretic. Diaphoretic means sweaty, okay? Sweaty when they shouldn't be sweaty, okay? So they start having these types of symptoms. If this is not taken care of and it gets worse, eventually it leads to this, where it is completely blocked with 0% blood flow that can lead to an AMI, acute myocardial infarction, or heart attack. So, cardiac disease is the placeholder for these types of diseases: atherosclerosis, angina, and acute myocardial infarction. Does that help?
Yeah. How about a coronary artery disease?
Coronary artery, same thing. So, cardiac disease, coronary artery disease, exact same thing.
Okay.
Now keep in mind, here's the thing, medicine does this. So you've got cardiac disease, you've got coronary artery disease, same thing, and then you've got acute coronary syndrome, same thing. All of those mean these sets of disease processes. Anybody else? Okay. So, in many situations, it's not going to be possible for you to distinguish between a patient who's having angina or an MI just simply based on your history that you get from your patient as well as your physical exam. Again, you got to remember in that situation, we got to default, Blake, to what's going to kill our patient first. Angina cannot kill your patient. Your patient, Ryan, can have chest pain, they can be discomfort, they can have nausea, they can sweat, but angina can't kill them. An MI can kill your patient very, very quickly. So again, when we come in, we start with a worst case scenario and then we work our way back. And so this is one of the things that you got to learn as far as when you're going in through there. Some of the things that you're going to do as far as your assessment goes is that you're going to talk to your patient. Find out about their history, Cam. Look at them and ask them, do you have any cardiac history? And one of the things that you're particularly wanting to look at here, Chase, is going to be their past pertinent history. Now, some patients, when you start asking them about their history, they'll say, let's say it's a 65-year-old male. And they'll start, well, yeah, when I was 5 years old, I fell out of a tree and I broke my arm. Okay? That's their past history. It's not pertinent to what we've got going on. Now, be very careful here, folks, because you got to be very gentle to redirect the patient, because all you've done is you've asked them for everything that has ever been wrong with them. But we want to redirect them to what's going on right now. So don't look at them, Suzanne, and say, well, that's not really important for what's happening right now. But just simply say, okay, all right, that's helpful. Now, can you tell me more about your cardiac history? Do you have a history of having chest pain? Have you ever had an MI? And kind of gently redirect them. Because if you offend your patient, Teray, they're going to shut down. They're not going to talk to you. And the patient may die simply because of our being what they perceive as being rude to them, Haley. So again, redirect them back. So you're going to do a 12 lead. In just a few years, you guys are going to be doing blood work at the side of the patient to run specific cardiac enzyme levels that will be able to tell you, Cam, within about 10 minutes, regardless of what you see on your monitor, regardless, Joe, of what the patient's telling you, that yes or no, this patient is not having an MI. They're small handheld devices. I have one down in my office right now that we occasionally will use in the advanced sequence. And then you're going to do your physical exam. Talk to your patient, listen to your patient, and then lay your hands on your patient and look at everything. And just like puzzles, you're going to take all those pieces and you're going to form something that's going on here, okay? So let's talk specifically about angina. Angina pectoris is Latin, and you'll find a lot of Latin in medicine, but it's Latin for choking in the chest. I'll never ask you the Latin interpretation, okay? But basically, you have, as I said, with angina, you have more oxygen demand than you do have supply. That can come about because of two reasons. What were the two reasons that we've already discussed today? What two things can cause a patient to have angina?
The O2 demand is higher than the supply.
But what can lead to that? What are the two situations?
Inflammation.
That's the early part. So let's progress a little bit further.
So a clot.
Clot. So you got a clot. That's one of them. What's the other one?
Dysrhythmia?
Say it again?
Dysrhythmia?
Nope. It can result in a dysrhythmia. What's the other one we talked about? Vasospasm. Okay. So that artery spasms down primarily from people that use amphetamines. And now the diameter of the lumen of the artery is too small. Not enough blood can get through. Okay. Now, it can be triggered or brought on by exertion, by cold weather, by stress, or anything that causes the sympathetic nervous system to activate. So that's what you want to kind of think about. All right. The sympathetic nervous system is working. And so one of the things that you want to do is that you want to, as much as you possibly can, now begin to offset or turn down the sympathetic nervous system. What are some things that you could do to do that? That have nothing to do with giving a medicine or doing any kind of a procedure. Bella.
Take deep breaths.
You can tell your patient to take deep breaths. Why? Because number one, that's going to slow your heart rate down. Okay? It's going to slow your heart rate down, which guess what? It's going to reduce your oxygen level. MG.
I was gonna say that.
Okay. What else could you do? Like,
Vagal maneuvers.
you could do vagal maneuvers, but now that's more so for really fast heart rates such as SVT. Okay. Now we might do vagal maneuvers if our patient's having chest pain and they've got a really, really fast heart rate. But we probably don't want them to do vagal maneuvers if they've got a bradycardia. All right. What else?
They just like sit them up.
Yeah. The key word there is sit. Okay. So if they're standing, if they're moving around, have them sit, have them lie down. Right? When you're dealing with cardiac patients, you don't want to walk them out to the ambulance. Okay. There was an ambulance service here in Kentucky a few years ago that got into a huge lawsuit because they walked a heart attack patient out to the ambulance. Before the patient got into the ambulance, they went into cardiac arrest. Why? Just the act of walking exceeded the amount of oxygen that was available, and it caused these patients to go into arrest. And be compassionate. This compassion is more than just good public relations, Chase. Compassion says that if you're coming to take care of me and I perceive you as being a compassionate person, I know you're going to do what's best for me. I can trust you. Therefore, my anxiety begins to come down. Sympathetic nervous system begins to come down. O2 demand begins to come down, and the O2 supply begins to go up. So that's where compassion comes in. Like I said, it's more than just good public relations. It's the start of good medicine. All right? Now, there's two types of angina that you need to be aware of. Stable and unstable. Okay? Stable angina is when you can predict when it's going to happen, or you can predict what will take it away. The example I like to use is, let's say we're downstairs and you've got a patient who has called you. And the patient says, I know, Juju, I can walk up one flight of stairs and my chest is going to start bothering me. I'm going to get a little nauseated and maybe I'll have a little bit of trouble breathing. But if I stand there for 30 seconds or a minute, Haley, all of that goes away and I can go up another flight of stairs if I need to. Or if a patient just begins having chest pain, Lucas, they know that if I sit still for just a minute or so, that begins to go away. So if a patient can predict what's going to cause it or what's going to cause it to go away, that's stable angina. Okay? Unstable angina is a change in either one of those. So, Joe, instead of our patient that could walk up a full flight of stairs, now he can only walk up a half a flight of stairs, and now it's starting to cause him chest discomfort. That means that our blockage over here has increased. It's gotten worse. It's reduced even more the amount of blood that can get through distal to where that blockage is. Or now he's climbing the flight of stairs, Haley. He gets up there. Oh, yep, there's the chest pain. Now it's back. Let me stop here and rest for a minute like it always does. A minute goes by and he's still hurting. 2 minutes go by and he's still hurting. 3 minutes goes by and it's starting to go away. Or the patient is at like 4 minutes and he thinks, man, I think I'm going to have to take a nitro. And so now he has to pop a nitro in. Again, so unstable angina comes about because something has changed that causes its onset or it going away. Now, one of the things that's really important for you to remember is that if you've got a patient that calls you at night and their chest pain has awakened them from sleep, that's a bad sign, okay? For a patient to have angina at night when we're sleeping, when we are at the most relaxed state that we're in for our entire 24 hours, is a terrible, terrible sign for our patient. Now, by the time you get there, MG, the patient may say, the pain is gone. I'm sorry to have bothered you. I took a nitro and it went away. You really, really need to get that patient to go in with you to the hospital because their blockage has gotten to the point that something happened during the night. They had a dream or something increased the sympathetic nervous system, and it caused them to have this angina while they were sleeping. So obviously we can't make patients, Blake, go to the hospital. They don't want to go to the hospital, but you got to try to convince those patients to move on. Questions about angina? MG.
So unstable angina, and you said stable is like predictable, start, stop. You don't know what causes it, an indicator. But unstable, you think it's predictable, but it just keeps going.
Well, or it's not predictable. Something changes now, like I said. Now instead of a full flight of stairs, I can only go up half a flight. Something changes as to what causes its onset, or something changes that addresses how bad I'm, or what in the past has made it go away.
Okay.
All right. Anybody else? All right. Then we move into myocardial infarction. Acute myocardial infarction. Acute meaning sudden onset. Myo meaning muscle. Cardial meaning heart. Infarction meaning death of tissue. So it's a sudden onset of death of cardiac tissue. Now, this happens, just like I got over here on the board, when the artery in the heart is 100% completely blocked. The area distal to that, downstream to that, now becomes starved for oxygen, and the patient begins to have discomfort. I tried to use the word discomfort because many times, Lucas, your patients will not say, no, it's not hurting, it's just burning, or it's pressure, or it's squeezing. All of those are keywords that you need to be familiar with when it's in this particular area here. Okay. Now keep in mind that the pain can be referred to anywhere, Ryan. Remember, referred pain means that it starts in one place and it goes to another. So cardiac pain can be simply right here in this area. This is called substernal cardiac pain. Substernal cardiac pain. Substernal, sub meaning under the sternum. It refers to cardiac. And it can not refer anywhere. It may be just right here. But your patient can also, Blake, have pain that goes to one or both shoulders. It can go down into the stomach. It can go up into the neck, into the jaw, into the teeth, or out through the back. Okay, so you want to make a note of those as far as when the patient helps you to describe this. Here's the other thing that's critical for you to understand. Many times patients that are having an MI will have this sense of impending doom. They'll look at you, Ryan, and they'll say, I feel like I'm going to die. Why is that? They're not getting enough blood to the brain. That is a type of altered mental status, and it should concern you greatly, because if we can't get blood from here to here, Houston, we have a problem. Okay? I will tell you further, take these patients serious, Haley. I used to work for Rural Metro EMS down in Knoxville back in the 80s. While I worked down there, I had 3 different patients look me in the eye and MG say, I feel like I'm going to die. And they did. They either died before I got them to the hospital or shortly thereafter. And that's a pretty strong indicator that we've got some really major damage that's done over here to the left ventricle. Now, what would you want to be aware of are atypical presentations. When you see the letter A, and it's not part of another suffix, so trying to think. Let's just go with this particular word. Atypical. A means the absence of, and typical means usual, okay? So atypical would mean these are symptoms that are not normal. Now remember, on the left side of your chart here, you see the classic symptoms of a patient having a heart attack. Chest pain, radiates out anywhere. They can have nausea. They can have vomiting. They can have diaphoresis. They can have shortness of breath. This is the classic presentation of your patient that's having an MI. There's two subcategories of the population that will often not have this, and their only complaint is going to be a sudden onset cam of unexplained fatigue. Okay? The patient will call you, and CC will say, I was doing fine today, but 30 minutes ago I just got so tired. I don't have the energy to raise my arms up. I'm exhausted, and I don't know why. Okay? These two subpopulations are going to be females and diabetics. Okay? Diabetics because their nervous system has been damaged by the increased glucose that's going around, so they don't feel pain as extreme as what people who are not diabetics. We don't fully understand why women have these types of symptoms, but this is one of the reasons why in the past we used to say, well, cardiac disease is a man's disease, when women were actually dying from cardiac disease at almost the same rate as men, but they weren't diagnosed with that because they were complaining, their chief complaint was unexplained fatigue. So, ladies and gentlemen, if you've got a patient that is a diabetic or a female, and especially if you've got a patient who is a female who is a diabetic, and they tell you, man, I'm just exhausted, I don't know why. Little alarm bells should go off, and a little evil angel bill should pop up here on your shoulder. And you should assess that patient for being an MI patient. They may not be. They could have other issues that are going on. But remember, we want to rule in or rule out the worst possible thing first. MG.
I know diabetes, there's type 1 and type 2.
Mm-hmm.
If the patient is diagnosed with hypoglycemia, is that a type 1 type deal, or is that official you have diabetes? Or
diabetes comes about when you go in and you run a certain number of tests, and over a period of time, your blood sugar is elevated, not low. What you're describing is a patient can have a tendency towards hypoglycemia, okay, which is a type of diabetes, but it's really rare, okay. Most of the time, people have too much glucose in their blood, and that glucose, for those of you that are in my pharmacology class, we were talking about this yesterday, will dissolve the nerves in the body, and your patient won't be able to feel pain as intensely as anybody else. Anybody else? Questions? Okay. Other cardiovascular emergencies. We talked a little bit about aortic dissection. A dissection happens when you get a tear in the inner wall. Let me get my little laser pointer here. So we've got this tear right in here in the inner wall. And remember, blood is coming out this way, and so you'll start getting blood that accumulates in between the tunica intima and the tunica media. The tunica media being in the middle of the artery. And as we get more and more blood in there, then it begins to fill up, very, very similar to what we would see like with a water balloon. The outer lining of it gets very, very thin. And literally, if a patient is lying down flat, excuse me, and they're of small stature, you can actually see this pulsating mass in their stomach. It looks like something out of an alien movie, okay? Now, you would never see that in me. I've got too much fat tissue in my stomach, so that would be hidden. But if you got a person who is mostly muscle and they're laying flat, now you're going to want to run, you're going to want to be very, very gentle with those patients, because if that ruptures, the patient will probably die in a matter of seconds. You want to get them to the hospital as quickly as you can, but also as safely as you can, because you don't want that aneurysm to rupture. These patients need to go to a trauma center. Why? There's no trauma involved. This is a cardiovascular problem, but you need to get them to a trauma center. Why, MG?
Because if it does start tearing, there will be massive amounts of blood loss that you need to go to a trauma center for, so they can have more in-depth surgery.
And okay, last word was correct. Surgeon. Yeah, if it ruptures if they get to the hospital, a trauma center will always have a surgeon on board, and they'll have the blood that they need to replace it, and they'll have the skills to go in and be able to take care of that. So take this patient to a trauma center. Another type of disease process is known as heart failure, or you'll hear older medics and myself, such as myself, call it congestive heart failure. Now, let me try to illustrate it for you here. So here's our heart. Aorta is up here, ventricles are down here. When the heart tissue dies, what did I say are the two things that it will not do? It will not contract, and it will not conduct electricity. And we can actually see this on certain EKGs that you'll learn to run in the advanced sequence. Here's the problem with this, is that the contracting force of the heart is reduced, and it can now lead into heart failure. And basically what it's doing here, Chase, is the heart fails as a pump, okay? Now, if you think about anything that's not related to medicine or to the body, when a pump fails, let's say that you've got in your basement, okay, we got rain that comes in. Sometimes people will put pumps down in their basement because they'll have a tendency to flood, so they can pump that out. If the pump fails in the basement and the rain's still coming in, what's going to happen?
Backflow.
Yeah, backflow where?
Are we talking in the heart or in the basement?
Basement.
In the basement.
It's going to happen in the basement. Yeah,
Up into the
it's going to
house.
happen in the basement. All right, so this is why understanding the flow through the heart is so important. Now remember, we've got two vessels that come in over here that bring blood back to the right atrium. What are those two vessels called?
The inferior superior vena cava.
Very good, very good. So we've got superior vena cava and we've got inferior vena cava. And it's perfectly okay to abbreviate those that way, okay? And then over here, we've got blood that comes back into the heart from the lungs. And what's that called? Pulmonary veins, okay? Now, there's no abbreviation for that, okay? So you'll have to spell it out or abbreviate it like that. So there's two types of heart failure. There's left side and there's right side, okay? The most common cause of left-sided heart failure is an acute MI. That is what causes that's what leads to most causes of the left side of the heart to fail. What do you think would be the most common cause of right-sided heart failure?
Would it also be an AMI on the left side?
Yeah, maybe indirectly, but the most common cause of left-sided heart failure is right-sided heart failure. I'm sorry. Of right-sided heart failure is left-sided heart failure. So the left ventricle fails, and then the right ventricle fails. So stay with me on this, and then we'll take a short break. When the left ventricle fails, now remember, the body is going to send out from the left ventricle into this artery, which is called what? Very good. Okay. So when the left ventricle fails and it's not able to send blood out in through the aorta, what's going to happen? Perfect. The fluid is going to begin to back up into the lungs. Now, how are we going to know that that's happening? Well, this is where we're listening to our lung sounds. And you will hear a sound that sounds like, or that is called crackles. Crackles. Okay? Sometimes I will slip up and call it its old name and call it rails. But normally it's called crackles. Crackles sounds like, let's imagine that you're out at your favorite restaurant and you're just about done eating and you've got just a little bit of soft drink left in your cup and it's still full of ice and you're trying to get that, you do that last little drop of soft drink before you go back to class. That sound that makes is very, very similar to what crackles are. Now, it'll be diminished and muffled because you still have all this tissue. But it's the sound of air going through thin water. Thin water, okay? Now, as it begins to worsen and we lose more and more of the left ventricle, remember we said that it can lead to right-sided heart failure. So this eventually fails, which means the pressure begins to increase over here, and now we begin to have failure of the right ventricle. What's going to happen? MG?
Beef it.
Well, if it's not corrected, yes, but before that, I'll let you know, I'll give you a hint. It's very, very similar to what's happening over here with left side heart failure. And how are we going to know that, Kim?
Let's see swelling in the feet.
Perfect. So if fluid begins to back up here into the superior and inferior vena cava, and we start seeing swelling. That swelling that you will see is known as pedal edema. Pedal refers to the foot, but for our purposes, we're talking about extremity. So you will look at your patient and they will have swelling in their feet, swelling in their legs. There is one type of patient that will not have that swelling, and that's the patient that's in a hospital bed. Remember, a patient that's in a hospital bed will typically have their head raised up, as well as their feet raised up just a little bit. Where would we find pedal edema on these patients? Say it again. The back. And in particular, the sacral area of the back. You'll see a kind of, it will just kind of look like a hump. And that's where their fluid will be. The fluid will go to the lowest area of the body. Okay? So I've got 11:09. Take a break, and we'll pick it right back up at 11:15. All right, so let's get started back. Susanna, will you close that door for me, please? So any questions about heart failure? Again, most of the time it's simply referred to as heart failure. You will have people that will have been in medicine for probably longer than 10 or 15 years that will occasionally call it heart failure. I slip up sometimes and call it congestive heart failure because that's what I've called it for my whole life. But again, those are the same things as far as when we're addressing those. There's not two different types of diseases. Cardiogenic shock comes about again primarily when the left ventricle fails as a pump. Okay, it can't push out enough blood. Now, cardiogenic shock can often be seen in patients that have left-sided heart failure. The other thing that you're going to see, in addition to the signs and symptoms primarily of pulmonary edema or crackles in the lungs is that you will see a patient that will be really, really sick. These are incredibly sick patients, and their vital signs will be down in the toilet. Okay, this typically happens when the 40% or more of the left ventricle is destroyed by an MI. Okay, so they show signs and symptoms of shock. They'll start out with a heart rate that's really, really fast because the heart body is trying to compensate. And then as it progresses, if it's not taken care of, it will begin to get slow. Understand this. A change in mental status, including your patient being restless or anxious, is an indicator of decreased blood flow to the brain. This is why it is so important that you don't blow off patients when you get to them, particularly on car wrecks, Blake, when you get there and they're just simply, oh, I'm nervous, I'm anxious, I'm afraid, and you say, oh, well, there's nothing wrong with you. You're just anxious. This is normal. Well, it could be. You have a car wreck. Yep, could very much be just that sympathetic nervous system, Joe, on overdrive. Or it could be the first sign of shock. All right? So make sure you take your time and assess your patient. For the most part in this class, all I want you to know are the signs and symptoms of these disease processes. When you get into 310, that's when we'll dig down deep and see what you can do for them. And there's a lot that you can do for them. Pulmonary embolus. Okay, pulmonary lungs. Embolus means something that's traveling in the body. Okay, a pulmonary embolus can be a blood clot. It can be a fat clot. It can be part of an IV catheter. It could be anything, but it breaks off and now it travels throughout the body. And what happens is it gets lodged right here in the lungs, in the vasculature of the lungs. Not the lung itself, but the vasculature that feeds the lungs, the arteries that feed the lungs. Signs and symptoms that you're going to see here will be your patient is doing fine 1 minute, and then bam, in an instant, they have a sudden onset of chest pain and shortness of breath. One of the things I want you to do is look at their legs, okay? Many times these patients will report having had red, swollen, or hot legs in the days or weeks leading up to this. That's known as PAD, peripheral artery disease. It's really similar to what we see with the cardiovascular disease, but it's down in one of the legs. And what happens in that situation, Lucas, is a blood clot breaks off, it travels through the body, and then it gets stuck in the vasculature in the lungs. Sometimes, Teray, your first sign or symptom that you'll see on this patient is sudden cardiac arrest. I've never resuscitated anybody back from a pulmonary embolus when they go into cardiac arrest. Not always do they go into cardiac arrest, but when they do, they generally are very, very difficult to get to come back. The other thing that you want to assess these patients for would be, if it's a female, you want to find out, does she take oral birth control pills, oral contraceptives, and whether she smokes. Oral contraceptives and smoking, either one of those, raises the risk for a pulmonary embolus or a PE for a female. You put them together, both, and it raises the risk dramatically, okay? You want to find that out. The last thing that you want to do on your assessment here is on the history, find out, have they been on a long international flight? Now, why would we ask that? What do you think, Joe? Why would we ask? Have you, and this would be of either gender. Why would we ask? Have you been on a flight?
Yeah, I've been on a plane before.
Yeah, but why would we ask them?
Is it because of the difference in pressure and the difference of oxygen amounts?
That's a minute part of it. Okay. So I'll take that part. Haley, why do you think?
If it's a long international flight, they're gonna be just sitting for about like anywhere. It could be like 17 hours or
Yeah.
anywhere.
Anything over about 6 or 7 hours, basically what they tell you on these flights is to do some leg muscles to keep the blood pumping through your legs. But sometimes people will take really long international flights. You take a flight out to like Australia, and there are nonstop flights out of like New York and LA that will go to Australia. You're looking at 17 hours, and then you want to find out from them, have you been sitting for that long? Because it will cause the blood to pool in the leg. And what does blood have a tendency to do when it sits still? It has a tendency to clot. Okay. Any questions about a PE? Yep.
So if it's like primarily like a lung issue, like how does the periphery or the red hot legs or like how's that come into hand with that?
That's where it starts. So many times what you will have is you'll get a blood clot that will develop in the legs. Same process as what we have here with this clot that's in the artery of the heart. Patient will often complain of pain or tiredness. They'll say, it feels like that my leg is really, really heavy and it's hard to move it. The other thing that you'll see with peripheral artery disease is they'll complain of it beginning to swell and it gets inflamed. Remember, inflammation is the start of your cardiac disease here. Inflammation is the start of your peripheral artery disease as well. And that leads to it being hot. At some point in time, part of this clot right here will break off and now travel through the body and get hung up in a really small or a medium size, depending on the size of the clot, artery that's in the lung. And that's what causes the sudden onset of the symptoms. Good. Anybody else? MG?
You specified for females if they smoke and take oral birth control. What about the implants, like IUD, Nexplanon? Don't worry about that.
Don't worry about that.
Just the oral.
Just the oral or if they smoke.
Okay.
Yep. Anybody else? Hypertensive emergencies, okay? The thing I want you to understand here is that hypertensive emergencies are short. Let me back up. They are slow-moving emergencies, okay? Many times a patient will have an elevated blood pressure, Lucas, and not even be aware of it. But if it's not treated, that blood pressure will continue to go up and up and up. So some of the things that you will see here with a patient that is having a hypertensive emergency, sometimes people will refer to it as a hypertensive crisis, is a blood pressure of anything greater than 180 over 120. Now, that does not mean that if you got a blood pressure of 170 over 110, Cam, that your patient's out of the woods. That's still an incredibly dangerous blood pressure, okay? But some of the things that you will see in this regard is that you'll have unilateral weakness on one side, visual disturbances, again, often on one side, okay? They'll complain of just a severe headache, a really, really bad headache. And if we don't get that blood pressure down, that can lead into a seizure. They can eventually, if the artery in their head pops, now we have a patient that's having a hemorrhagic stroke. Thing to remember. If you run a patient, CC, and their chief complaint is a nosebleed, don't stop that nosebleed until you check their blood pressure. Why?
Because the nosebleed is releasing the pressure from the
Much better to have a vessel in the nose break open and bleed than a vessel in the brain. Okay? So, check the blood pressure prior to stopping that nosebleed. Okay? If the pressure is, they're in a hypertensive crisis, 190 over let me back up, 220 over 100 over 190, 195. Now what you're going to need to do is you can use your medication that you will have in your drug bag to slowly bring down that blood pressure. All right? So again, check the blood pressure prior to stopping a nosebleed.
So if the patient's been bleeding and they do have a real bad high blood pressure, you just let it keep bleeding like that.
Yeah, you just give them a basin and let them drain into that until you come up with a plan of what you're going to do. Explain to the patient what you're doing and why you're doing it, so they don't think that you're just blowing off the fact that, oh, he's just got a nosebleed. Because that could be really serious. So just simply say to the patient, okay, I need to check your blood pressure first, because if it's really, really high, we don't want to stop that bleeding yet, because if we stop it and a vessel ruptures in your brain, you're going to have a stroke. And for hemorrhagic strokes, there's really nothing that can be done for those patients. Blake.
What if the patient's on blood thinner?
Oh, now you got to go and make it worse. Again, we want to keep that in mind, but again, the blood thinner is not going to kill our patient as quick as if we get an artery that ruptures. Because if we get an artery that ruptures in the brain, trust me, it's going to bleed really, really fast. And again, another thing to keep in mind is that the brain likes blood. It's a blood hog as long as it stays within the vasculature. When you have a rupture, either from a medical problem or a traumatic problem, and blood comes into contact with the brain tissue, it seizes up, and your patient has a terrible, terrible, intense headache. They'll often refer to it, Bill, as this is the worst headache I've ever had in my entire life. So we want to take it slow. That's a good scenario, because you could very well be faced with that. Now first of all, blood thinner. Now what do we want to do? We want to stop it. We want to let it bleed. Well, we got to get that blood pressure down. In many situations, if we bring the blood pressure down, the bleeding will also stop. Good observation. Anybody else? All right. So what do we do for this? All right. So basically, a lot of this is just simply going to be assessment. I'm not going to go really, really deep into any individualized type of treatment. Okay. Your initial assessment and your secondary assessment. Your initial assessment is that we're looking at what's going to kill my patient in the next couple of minutes. Your secondary assessment is to identify life-threatening problems that may kill your patient from the time you go, if you complete the secondary assessment to the time you get them to the hospital. Okay? When we're looking at this, you got to answer a question. Is my patient sick or not sick? So your patient is sick if they can indeed die unless you do something to help them. Okay? A not sick patient is one who is not going to die. Does not mean that they're not feeling bad, Ryan. Does not mean that you do not need to treat them. But you can go, okay, wait a minute. I got a little bit of time here. I can relax just a little bit. Okay? So that's the difference between sick and not sick. The things that we're going to be looking at here are your key indicators. Respirations. The first question we want to ask about respirations is what?
How fast you're
Not how fast. That's an important question. It's not the first one.
Is it labor?
Nope, that's an important question. Somebody up here.
Do they have respiration?
Do they have respirations? Okay. Are they breathing or are they not? Okay. So think of this as kind of a branching scenario where you come and you're asking questions. Are they breathing? Yes. Okay. Now we'll go on over here to find out. Is it labored? Is it fast? Is it slow? And we can do things to address that. But if our patient's not breathing, we got to do what? We got to breathe for them. Okay. We got to ventilate them. Yeah, you're exactly right. I hope everybody gets this question. What's the first question you're going to ask about the pulse? Do they have one? So assessing pulse and respirations are really, really similar, okay? Do they have one, okay? Is it fast or is it slow? Is it weak or is it strong, okay? Next thing we want to find out, look at their mental status. Keep in mind, altered mental status is the earliest indicator of poor perfusion of the brain. One very common type of altered mental status is anxiety. Don't just blow your patients off. The other thing is we're going to look at the patient's skin. The skin does not get enough respect. Okay, we think about the heart, we think about the lungs, we think about the brain, but the skin will give you a ton of information. Okay, you look at the patient's skin, you touch the patient's skin. In doing so, we're looking for color and condition. If the patient is pale, that might indicate that they're bleeding out. If a patient is red, it might indicate that they're either really hot or maybe they have carbon monoxide poisoning. If the patient's skin is blue, that means that they're cyanotic and they're in really bad respiratory distress. So the color of the skin, the condition of the skin, is your patient diaphoretic or not? Okay. What's the temperature of the skin? Are they pale? Are they cool? Are they warm, like they should be, or are they hot? And all of that will give you a lot of information. Look at your patient's body position. You will rarely find a patient in severe respiratory distress lying flat. If they're in severe respiratory distress and they're lying flat, they're getting ready to go in respiratory arrest because they don't have the energy anymore just to help themselves sit straight up. Make sure you memorize this chart. You will see it on your exam. This is how you begin to get your patient's history, and we use OPQRST. O meaning onset. What was the patient doing when the pain started? If he was running a marathon and he started having chest pain, that's something that's important. P, provocation or palliation. All right? Two big words. Provocation means what makes it worse. Okay? Palliation means what makes it better. Remember, what did I say to you that if your patient says, Blake, my pain gets worse when I breathe in, but it gets better when I breathe out. What does that tell you? What disease is it probably not? MJ, help him out.
Would it not be cardiac?
It's probably not going to be cardiac, okay? So again, provocation or palliation, and we can poke around on our patient's chest. Don't put your fingers all the way to their backbone, but just gently push and say, does any of this hurt, okay? Q is quality. Ask them, Ryan, to describe it for you. Don't play 20 questions of saying, is it sharp? Is it dull? Is it pressure? You'll be there all day. Just simply say, what's it feel like? Describe it for me. Radiate. Now, whatever you do, don't ask your patient if their pain radiates somewhere. They're going to think something like nuclear or something like that. Just ask them. Okay, so you're hurting in your chest. Does it go anywhere else? Now, that's a big, big different question, Haley, than saying, do you hurt anywhere else? All right? So what you want to ask them about the radiation is, does your pain go anywhere else? Okay? And then your severity. You rate it on a scale of, this says 1 to 10, but we actually rate it on a scale of 0, absolutely, positively, no pain, to 10, the worst pain in your life. I don't like pain scale scores because patients will lie to you because they'll think, Blake, if I tell him it's a 10, he'll get me in to see the doctor a lot quicker, okay? Now, again, a 10 would be like your head has been cut off and they're dipping you in really, really strong salt water with what's left, okay? It's that kind of pain, all right? And so find out and then assess them periodically through your transport. Does it get better or worse, okay? And then time. When did this start, okay? When did it start? Did it start an hour ago, Teray? Or did it start last night? All right. When we're looking at our patient, we want to do a physical exam. This is how we lay our hands on the patient. Listen to your patient's lungs. Now, it says to start at the bases. Now, I want you to understand the base of your lungs are not located up here. Your lungs, the apex of the lungs, the front, the top part of the lungs start up here, okay? And they go back this way. So when you're listening to the bases of the lungs, you're listening right here at the very lower part of the thorax. It says start at the base. It doesn't matter. You can start there and work your way up. Most people will start here and work their way down. Where do you listen? You listen here and here, and you compare. They should be the same. Then you listen here and here. Notice the transition, and they should be the same. And then lastly, you listen at the bases, right there at the bottom part of the thorax. Listen to one side, then listen to the other. You always compare left to right, not up and down. Left to right, up and down. Look at your skin. We've already talked about assessing the skin. Get that ton of information that it'll give you to you. Pulse oximetry, okay? You'll learn more about pulse oximetry, but it measures the percent in your EMT class, if you haven't already taken it. But it measures the percentage of blood that, or the percentage of oxygen that has attached to your hemoglobin by using a little probe here, all right? If you've got a patient that has an altered mental status, regardless of the cause, you're going to get a blood sugar on them. Okay, so we're going to look for a low blood sugar. If your patient is saying, I'm having a chest pain, and then they suddenly begin having, saying silly things, now, yeah, we're most likely, Joe, going to think, oh, the cardiac status has not improved. It's getting worse. And most of the time you're going to be right. But along with that, we want to do a finger stick and check for a blood sugar level. And then we're going to do a hands-on assessment starting at the top of the head, literally, and we're going to work our way all the way down to the bottom of the feet, literally, okay? Literally. Now, when we're listening, let me back up. Any questions on your physical exam? Okay. Lung sounds. We've already kind of talked about the lung sounds as far as you do them or where you find them. Listen to your lung sounds in a quiet place. It will be difficult, if not impossible, for you to listen to lung sounds and then heart tones in the back of your moving ambulance. All ambulances are diesel. They make a lot of noise. They're large trucks with large tires. Driving them down the road, you'll get a lot of road noise. So listen to those prior to going en route. Now, I'm not going to tell you it's impossible to hear lung sounds and heart tones while you're driving. It's just very, very difficult, all right? When you do this, ask your patient to take a deep breath through their mouth and then to blow it out through their mouth. Ask the patient, if they don't mind, to turn their head away from you, especially in this day and age of everybody's got some type of a respiratory infection going on. So what you don't want to do is you don't want to expose yourself. So when you're standing there and you're assessing the patient from the front, the last thing you want is the patient to be breathing really deep exhalation breaths on you. If you can, try not to listen through clothing. Put your stethoscope against the patient's skin, okay? Now, I've got some lung sounds. I don't think I've got the files attached to this particular presentation, which means I will upload them when I get down to the lab or get down to my office. And I want you to listen to them because part of your next exam, right at the very beginning, is going to be the identification of lung sounds. So let me see if this is going to play. me, first of all, turn the volume up. It is playing. That's a normal lung sound, okay? That's what your breath sounds or lung sounds will sound like on a normal basis, okay? What are rails or crackles? Again, the correct nomenclature today is crackles, but you may hear older medics, older people in medicine refer to them as rails. And again, rails or crackles sound like air that's moving through thin water. You hear the difference between what is normal. Okay, let's do that one more time. Okay, crackles. What did I tell you crackles were an indicator of from the cardiac perspective? Juju.
Oh, from the cardiac. Was fluid in the lungs, which lets you think that there's a left side of left heart.
Bingo. Bingo. Good. Now, the other breath sound that we have not talked about are known as. Okay, why did I have this? Hold on a second. That's the same one. I don't know why I doubled up on that one. Another breath sound that you need to be familiar with is a breath sound that's known as a wheeze. A wheeze comes about when the bronchioles are severely constricted. That's the passageways that takes air into and out of the alveoli, and it makes kind of a musical whistling sound. You hear it right at the very end. You hear it right at the very end. One more time. Sometimes you'll be able to hear wheezes on your patient without a stethoscope. Not a good thing. Not a good thing at all. So, there is one more breath sound, and I'll need to post it because it's not coming up on here, and it's called rhonchi. Rhonchi, remember, I said that rails sounds like air moving through thin water. Rhonchi sounds like air moving through thick water. Again, we go back, Ryan, to our food example. You've finished eating, maybe you're going out here to Steak and Shake, and you said, I'm gonna have a milkshake. Okay, so you're finished with your food, and you're down to that last few drops of your milkshake, really still thick. The sound that it makes of when you're trying to get it up with your straw, that is rhonchi. That is usually an indicator of an infection in the lungs. Okay, so crackles, as Juju said, is going to be for pulmonary edema. Rhonchi is going to be for infection in the lungs. All right. Now, I don't want you to worry anything at all about the treatment here. Not nitroglycerin, not aspirin. We'll learn more about that in advanced cardiology. So as we finish this out, these are some key things. Ischemia comes about when you have a reduction of blood flow, oxygenated blood flow, to the cardiac tissue. That results in patient having some type of discomfort. Acute coronary syndrome is the overall umbrella term for these multiple different types of cardiac diseases. Keep in mind that not all chest pain is cardiac related. It can be cardiac, it can be medical, it can be pulmonary, or it could be trauma. Go back and become very, 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 very familiar with the signs and symptoms of these cardiovascular diseases that I've got up here: angina, myocardial infarction, aortic dissection, and heart failure, as well as cardiogenic shock. Make sure that you are really, really strong in knowing the steps of the assessment, and in particular, those breath sounds, and I'll put a Ronchi up there a little bit later, as well as your OPQRST. And that, my friends, is where we're going to stop.